Today's topic is going to be about intussusception. So intussusception is a prolapse. We're going to start in this corner. Prolapse of the proximal intestine into the distal intestine. As you can see, I try to draw a diagram of the proximal intestine into the distal intestine. Right. So it is the most common abdominal emergency in children below the age of 2. The most common presentation is between 3 months to 6 years of age, although it does peak at about 6 months to 12 months. Okay, so that's when you will see the most intussusception cases. The cause of intussusception is mostly idiopathic, but it is thought that the Peyer's patches are lead points at which the intestine folds into itself and cause a prolapse. So that's why these prolapses are usually found at the ileocecal junction. So that's called an ileocecal intussusception, and that is the most common form or location of intussusception because that's where most of the Peyer's patches are. Next, when looking at clinical presentation, this is quite high yield when we talk about the classical triad or the classic triad, and it's not actually seen a lot in clinical practice where you'll have all three of this triad presenting. However, it is a lot of the times in exams, and they would expect you to know what the classical triad is. So the classical triad of symptoms include your intermittent colicky abdominal pain in the right upper quadrant. Okay, so that is where the ileocecal intussusception would usually occur, and thereby the pain would be in that location. It's intermittent, so it's not continuous. Colicky, so it almost comes and goes. It comes and goes with peristalsis, if that kind of makes sense. So it's like a spastic kind of pain, right? There's vomiting, not all the time, but they're part of the classical triad, vomiting. And bloody stools, this is a late sign, but the buzzword for the bloody stools is your red currant jelly stool. Okay, so if you see red currant jelly stool, think intussusception. Right. The other important things to note under clinical presentation is if the child has an altered mental status. So intussusception definitely has to be one of your top differential diagnoses if the child is unresponsive and within this age group. Okay. So on physical examination, this is also quite important. They say there is a palpable sausage shape in the abdomen, usually in the right upper quadrant. On rectal examination, you can find red currant jelly stools, buzzword, but this is a late finding. So, yeah. Important things to remember is that the most common location is in the right upper quadrant because it's ileocecal. The classical triad is important to remember. And then bullseye on ultrasound, we will get to that a little bit later. Red currant jelly stools, once again, buzzword important. Typical age group between 3 months and 6 years, but peaks at 1 year of age. So importantly, intussusception in children above that of 6 years, you have to suspect non-Hodgkin's lymphoma until it is proven otherwise, because as above 6 years of age, they usually don't present with intussusception then. So an important differential diagnosis would also be Hinoch-Schonlein purpura, because the clinical symptoms look very alike to that of intussusception. So the two important differentials is your non-Hodgkin's lymphoma in a patient above 6 years of age, and then Hinoch-Schonlein purpura. That is not bound by age, so that can occur anytime. Okay, treatment. So, before we get to treatment, let's look at diagnostic imaging. So, diagnostic imaging, we would be able to diagnose it on an abdominal ultrasound. on the abdominal ultrasound, what you would classically see is either the target sign, that's also known as the bull's eye sign. So it's just a double ring, if you can say it like that, on the ultrasound. There on the inside, the inner ring is known as the intussusceptum, whereas the outer ring is known as the intussusceptions. Right, that's not very high yield, just need to know that it's either a bull's eye sign or a target sign. Okay, so complications, if we don't treat intussusception, complications will occur. And complications would first include your intestinal obstruction and edema, and that, if untreated, leads to ischemia. There's a decrease in blood flow to the tissues in this region where it has prolapsed. Ischemia and necrosis of cells could lead to perforation, peritonitis, and ultimately septic shock. So we want to find intussusception early and then treat accordingly. So the treatment for intussusception, very importantly, we can try rectal air insufflation. So that is the non-surgical way of treating intussusception, and it's 75% of the times it is successful. So when you treat with rectal air insufflation, there's about maybe 10% of the times where there's recurrent intussusception. So you've treated with rectal air insufflation, but then the patient comes back with intussusception again. And in those cases, you'll have to do further investigations just to make sure that the intussusception is not of other inorganic causes, for example, Hodgkin's lymphoma or other pathologies. Okay, so it's quite worrying, or you should do special investigations when the intussusception recurs. Okay, so next we could have surgical interventions. With surgical intervention, the indications for that would be peritonitis, concern of perforation, so you want to treat it surgically before it perforates, and if the patient is looking acutely ill. So acutely ill kind of ties in with the peritonitis, because acutely ill could indicate that the perforation has already occurred. And that is it for intussusception. So a brief